Now it's time for the case study segment, starting with fluid volume deficit. Miss J is an 80-year-old client admitted to the emergency department with reports of dizziness and episodes of lightheadedness when she stands up too quickly. She reports flu-like symptoms or manifestations with vomiting and diarrhea for the past 3 days. Oh, snap. Given the current scenario, which assessment data will be the nurse's priority to collect first? So go ahead and pause the screen and try your best to answer this question in about 60 seconds or less. Okay, let's break it down. Now, before answering any question, always think about the key words in the assessment data. So let's look at the key terms. Dizziness, lightheadedness when she stands up too quickly. So remember, this is orthostatic hypotension, our big test tip, that low blood pressure and dizziness upon standing. So the low blood pressure is priority here, since this can kill the client via hypovolemic shock, that's severely low blood pressure, making the heart unable to pump enough blood supply to the body. And the vomiting and diarrhea for 3 days, this is huge for fluid volume deficit, resulting in severe dehydration. Now the question asks for which assessment data is priority to collect first. So always think for priority questions, think about what can kill this client the fastest. So if you're only to check one thing, what would be the priority? And in this case, it's heart rate and blood pressure. Just think about the ABCs here: airway, breathing, and circulation. So in this case, circulation is a cardiovascular assessment. This is critically important to save this client's life, as low blood pressure can kill this client the fastest via hypovolemic shock. Now moving on, upon assessment, blood pressure is 82/48, and the heart rate is 110 beats per minute. Oh my goodness, 82/48 blood pressure is super low. So let's go ahead and call the nurse. Wait a minute, you are the nurse. So this client is on the verge of total cardiac collapse with that hypovolemic shock. So the question states, what does the nurse suspect as the underlying cause for the client's abnormal vital signs? So go ahead and pause the screen and try your best to answer this question. Now for the correct answer, fluid volume deficit. So remember, low blood pressure is from low fluid volume, specifically with clients that have been vomiting and having diarrhea for 3 days. This client obviously would have fluid volume deficit, so we'd expect that low blood pressure from that low fluid volume. Okay, moving on to question 3. What additional assessment data does the nurse expect based on the client's underlying problem? So once again, pause the screen and give yourself about 60 seconds to answer this question. All right, let's break this down. So before answering, always think about the patho behind the manifestations or signs and symptoms. The body has low fluid volume, so naturally the body's going to present low and little and even shriveled up. So we expect the body to be low weight, low blood pressure, and even weak thready pulses from that low fluid inside the vessels. And as far as labs, you already know that if the body is dry, then the labs appear high. So weight loss is the first answer, because remember, clients with fluid imbalances, weight loss means water loss. And we expect dry mucous membranes, of course, because dehydration dries the body. And weak pulses, those low little pulses from the low fluid volume. And increased body temperature, because when the body is dry, then the temperature is typically high. And lastly, increased hematocrit, because as we know, when the body is dry, then the labs appear high. Now moving on to question 4. What is the underlying pathophysiology for the client's hypotension and increased heart rate? So once again, pause the screen and try your best to answer this question. All right, let's break it down now, y'all. Okay, before answering, remember the key term we used for compensatory mechanism. The body's trying to create balance and make up for the missing fluid, right? So the heart will pump faster and move the little blood it has around the body to perfuse the organs. So the correct answer here, the client is hypotensive due to decreased circulating volume, and the heart rate is increased as a compensatory mechanism for the decreased volume and tissue organ perfusion. Yes, remember, the heart is working overtime here, trying its best to pump the little oxygenated blood it has around the body. Now lastly, question 5. What is the underlying pathophysiology for increased hematocrit in clients with fluid volume deficit? So once again, pause the screen. You got 60 seconds. Try your best. All right, let's answer this question. So hopefully, before answering, you remembered hemoconcentration is an indication of dehydration. Remember, that blood is very concentrated. Basically, the blood is turned to mud, that thick blood, because when the body is dry, well, the labs appear high. So the correct answer, hematocrit and possibly other electrolytes will appear falsely elevated because of hemoconcentration due to the decreased circulating volume. Serum osmolality is also increased due to hemoconcentration. So yes, increased osmolality means increased thickness of blood. Remember the memory trick. The blood is turned to mud. Now moving on to the case study for fluid volume overload. Mr. W is a 50-year-old client with a history of congestive heart failure, who is being seen in the clinic today due to a weight gain of 4 pounds over the last 24 hours. Oh snap, that's a lot. Upon assessment, 2+ pitting edema is noted in both ankles. Okay, so huge key words here for worsening heart failure. So, question number 1. Given the scenario, which assessment data will be the nurse's priority to collect first? So go ahead and pause the screen and try your best to answer this question in 60 seconds or less. Okay, before answering, always focus on the key words and see what it's telling you about the client. So the first key term here is congestive heart failure. Remember, when you see heart failure, always think HF for heart failure as HF for heavy fluid in the body, as the heart fails to pump blood forward. And again, think weight gain is water gain, specifically with the heart failure clients. So again, the key numbers that you should write down is 2 to 3 pounds in 1 day. So this question states 4 pounds in 24 hours. Whoa, that is way too much. This is definitely worsening heart failure, aka heart failure exacerbation. Now the next key term, or key number rather, is 5 pounds in 7 days. But this question talks about 24 hours. Now the last key term in the question is 2+ pitting edema. Remember, that waterbed skin from the heavy fluid. Now the question asks for which assessment data is priority to collect first. So again and again, for priority questions, think what can kill this client the fastest. So if you were to only check one thing, what would be the priority? So in this case, it would be blood pressure. Because remember, high blood pressure is very deadly. We're talking hypertension that is 140 systolic or more. This can lead to the hypertension crisis of 180 systolic, huge stroke risk. Okay, now look at this next part. The blood pressure is currently 158/98. Okay, that is way over 140 systolic. It's creeping up to that hypertension crisis, right? So question 2, what does the nurse suspect as the underlying cause for the client's abnormal assessment data, including edema, weight gain, and increased blood pressure? So go ahead and pause the screen and try your best to answer this question in 60 seconds or less. So let's break this down. Well, just remember your memory tricks here. So weight gain is water gain. For our HF, heart failure clients, we have to think HF, heavy fluid in the body as the body fails to pump blood forward. So the correct answer is fluid volume excess secondary to exacerbation of congestive heart failure. Now moving on to question 3. Which pathophysiological process is responsible for the client's pitting edema? So once again, pause your screen and just do your best to answer this in 60 seconds or less. Okay, let's break this down. The key term here is pitting edema, which is that waterbed skin, from all that high fluid pressure being pushed out of the blood vessels and into the surrounding tissues, called the interstitial space. So the correct answer is increased hydrostatic pressure. Yes, again and again, increased volume causes fluid to be pushed out of that vascular space and into that interstitial space, resulting in edema. Okay, now for question 4 in our case study. What additional assessment data does the nurse anticipate for this client? So once again, pause the screen. You got 60 seconds. Good luck. Now let's break it down. So once again, think about the patho here before thinking about the manifestations or signs and symptoms. So the body has high fluid volume, right? Like a big bulging water balloon. Naturally, the body will present big and bulging, with big weight, big blood pressure, and big bounding pulses. And as far as labs, you already know the patho. We have less concentration of particles in the blood as fluid dilutes all the blood. So once again, the memory trick is when the body is liquidy, then the labs are low. Remember those low liquidy labs from hemodilution, that very diluted watered down blood, which I call hemodilution. Very low labs. Okay, now looking at our answers here. Bounding pulses, which we would expect from a lot of fluid, and decreased labs. So decreased hematocrit, decreased serum sodium levels, as well as decreased urine-specific gravity. So once again, when labs are low, the body is liquidy, a very dilute body here. Now moving on to question 5. What is the underlying pathophysiology for decreased urine-specific gravity in clients with fluid volume excess? So once again, pause your screen and you got 60 seconds. All right, let's break this down. So always, before looking at the options or thinking about the answers, always use the key terms in the question. So decreased urine-specific gravity, you remember decreased weight, or basically low weight, like gravity, right? And fluid volume excess, we have too much fluid. So again, you have to think diluted blood from too much fluid. Very light liquidy urine, that low weight from that fluid dilution. So the correct answer is in clients with excessive fluid volume, there's an excess of very dilute urine with a decreased specific gravity. So now you can see how all the manifestations come together if you simply know the patho of what's happening in the body. So remember, always think of the patho first and then look for the signs and symptoms. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free to share the love, share with the class. Now moving on to the case study for electrolytes. So the nurse is caring for a client with the primary medical diagnosis of acute renal failure, secondary to treatment of a urinary tract infection with a nephrotoxic antibiotic. The client's morning basic metabolic panel, the BMP, reveals the following abnormal data. So sodium is 135, potassium 6.5, calcium 7.1, and phosphate 5.3. Wow, a lot of numbers there and a lot of keywords. So question 1, which electrolyte levels are out of normal range according to the client's BMP? So go ahead and pause the screen and try your best to answer the question in about 60 seconds or less. All right, so let's break this question down and let's see which values are out of normal range here. So as stated before, you should write down and write out these normal values at least 10 times per day the week of your exam so that you can memorize them. All right, so here we go. Normal sodium, that Na, is supposed to be 135 to 145. Now the BMP shows 35. Okay, cool. We're normal, but barely normal. Now potassium, that K+, normally between 3.5 and 5.0. So at 6.5, whoa, okay, that's super high. Remember, potassium pumps the heart and the muscles. Huge risk for heart dysrhythmias. Now, in terms of calcium, that's Ca+, normally between 9.0 and 10.5. So we have a 7.1 here. That is pretty low. And we know when calcium is low, well then phosphate will be high, since they work inversely. So phosphate is 5.3, which is high, as expected, because normally it's 3.5 to 4.5. So the correct answer is K, or that potassium, that is high, hyperkalemia, and calcium that is low, that hypocalcemia, and phosphate is high, that hyperphosphatemia. Now moving on to question 2. Which assessment data will be the nurse's priority to collect first according to the above electrolyte abnormalities? So once again, pause the screen and try your best to answer the question in about 60 seconds or less. All right, look at the key words here. The assessment data that is priority to collect first. So once again, any priority question, always think what kills the client the fastest. So in this case, we have potassium that's high, calcium that's low, and phosphate that is high. So we know that the 3 P's of potassium, remember, P for potassium is priority since it pumps the heart muscles. So with high potassium, we have high pumps. Huge risk for cardiac dysrhythmias like VFib and even cardiac arrest. Very deadly. So the answer is a heart rate and rhythm to collect. The client is at a high risk for dysrhythmias due to that hyperkalemia, that high potassium. So once again, just remember the 3 P's of potassium. This is high potassium, which means high pumps of the heart. Now moving on to question 3. Which additional assessment data does the nurse anticipate in the client with hyperkalemia? So once again, pause the screen and try your best to answer this question. All right, so let's break it down. This question's asking for additional assessment data for hyperkalemia, that high potassium. So once again, think high pumps for high potassium. And remember, your top 3 here. We have peak T waves with ST elevation and severe VFib and cardiac arrest, as mentioned before, and hypotension and bradycardia as the heart cramps up from that high pumping from that high potassium. Now, neuromuscularly, it'll be high as well, with increased DTRs, paralysis and paresthesias, that tingling, and even profound muscle weakness. And in the GI, we have high pumps as well, so diarrhea and hyperactive bowel sounds. So in this case, the correct answer is paresthesia, that numbness and tingling sensation, muscle weakness, hypotension, and increased DTRs, those deep tendon reflexes. So remember, high potassium means high pumps. Now moving on to question 4. What assessment data does the nurse anticipate in clients with hyperphosphatemia, that high phosphate? So once again, pause the screen. You got 60 seconds. Try your best. All right, so let's break this down. Always before looking at the answer options or even considering to answer, look at the key terms here. Remember, hyperphosphatemia is that high phosphate. And always consider what you know about phosphate. So in this case, we know that phosphate and calcium work as an inverse relationship. So with high phosphate, just think low calcium signs and symptoms. So the top 3 signs and symptoms that you should know is Trousseau's and tetany, as well as chavostics or just vostics, and even weak B's, so weak bones, blood, and beats. So the correct options is tetany, chavostics or vostics, and Trousseau's, which is that arm twerk with the blood pressure cuff on. And lastly, question number 5. What is the underlying pathophysiology behind this client's hypocalcemia? So as you can see above, look at the case study and focus on the key words here. So let the question help you. So go ahead and pause the screen and once again, try your best to answer this question in about 60 seconds or less. All right, so let's break this down. This question is asking what is the root cause of this low calcium, that hypocalcemia? Well, let the question help you here. The key term is that the client has acute renal failure, which is basically broken washer machines of the body. So the body cannot clean the blood and drain excess phosphorus out of the body and into the potty. Naturally, phosphate will go up, making it high, which in result makes calcium low. Now, looking at the answer. Due to the client's acute renal failure, the client is unable to excrete phosphorus readily, leading to a state of hyperphosphatemia. Calcium and phosphorus have an inverse relationship, leading to hypocalcemia, that low calcium, in these clients. Exactly. So now you can see how knowing the patho first will ultimately help you understand what's going on in the body and finding the correct answers.